is 85 to 95% is water, and the remaining 5 to 10% is cholesterol. Okay. Now this cholesterol normally the cholesterol is fat soluble, but in bile it is made water soluble. By micelle formation. This we already know. Now, which structures help in formation of micelle? This is bile acids and lecithin. So, bile acids and lecithin, they help in formation of micelle. Okay. So, whenever there is increase in the cholesterol content, or there is decrease in bile acids or lecithin, so this will lead to cholesterol precipitation. Okay, and there is a possibility of cholesterol gallstone. Other factors apart from that are nucleation, or nucleation can occur because of any infection in which the small microcrystals can become big stone, and in presence of stasis also due to prolonged fasting, prolonged TPN, burns, shock or any other disease. If there is decrease in the release of cholecystokinin, then there is a gallbladder stasis, and this will add on to the formation of gallbladder stones. Okay, so this is regarding the pathophysiology of cholesterol gallstones: increase in cholesterol or decrease in bile acids or lecithin. Okay, so now we'll first discuss what is the most common type of gallstone. So the most common type of gallstone worldwide is mixed gallstone. Okay, if mixed gallstone is given in the option, then this is the best option. Then most common type of gallstones in Western world, or if mixed is not there in the option, then we'll go for cholesterol gallstones. Okay, if mixed is given in the option, then we'll go for mixed gallstones. Okay, most common type of gallstone in Asia or India, it is pigmented gallstones. Okay, this pigmented gallstones include both black and brown. Okay, in India, pigmented. Overall worldwide is mixed. Okay, now regarding the pathophysiology of gallstones. First, we will discuss cholesterol gallstones. Now, there are three factors which are important. First is lithogenic bile. Then second is nucleation. Then third is stasis. These three are important: lithogenic bile, nucleation and stasis. Okay. Now, in lithogenic bile, I have already told you three components are important. First is supersaturation of cholesterol. Then second is bile acid deficiency. Third is lecithin deficiency. Okay. Now, supersaturation of cholesterol can occur because of obesity, increased cholesterol intake, or because of clofibrate therapy. because of obesity, increased cholesterol intake, and because of clofibrate therapy. Now, regarding this bile acid deficiency, this we know that there is enterohepatic circulation and the bile gets absorbed from the terminal area. Okay. So, in case if there is any terminal ileal disease or there is terminal ileal resection due to any reason, or in cases of short bowel syndrome, this bile acid will not be absorbed and there will be no enterohepatic circulation or less enterohepatic circulation. This will lead to loss of these bile acids and will increase the possibility of gallstones. Okay. So, there is any ileal disease or ileal resections or use of any bile acid sequestrant like cholestyramine, or because of any mutation like CYP7A1 mutation. Okay. And the third point is lecithin deficiency. Okay. This lecithin deficiency can be seen in MDR3 gene mutation. Now, the next point is nucleation. Okay. So, in nucleation, what happens is the microscopic small crystals, they join together and they aggregate to become a big crystal or macroscopic crystal. Microscopic becomes macroscopic crystals with the help of nucleation, and this nucleation occurs because of infection or because of mucin glycoprotein. Okay. And now this third point is stasis. And stasis can occur due to any reason in which the patient is unable to take orally for a longer period of time and there is lack of release of cholecystokinin. Okay. And the reasons can be prolonged fasting, can be prolonged TPN, OCP intake, massive burn, octreotide, or pregnancy. Okay, so these all are the causes of gallstones formation or the cholesterol gallstones formation. Okay, now the next point is regarding the pigment gallstones. I have told you that pigment gallstones are of two types, black stones and brown stones. Okay, so these are black stones and brown stones. Mainly, the brown stones are seen in CBD, black stones are seen in gallbladder. Okay, mainly, generally, they are seen in gallbladder and CBD. Okay, now, this black stone, in black stones, there are insoluble bilirubin pigment polymer of calcium phosphate and calcium bicarbonate. So, in black stones, it is mainly calcium phosphate and calcium bicarbonate. Okay, whereas the brown stones are comprising of calcium stearate, calcium palmitate, and calcium bilirubinate. Okay, so black stones are insoluble polymers of calcium phosphate and bicarbonate, whereas the brown stones are of calcium bilirubinate, calcium stearate, and calcium palmitate. Okay, now this black stones are seen in patients with chronic hemolytic anemia. Okay, and prosthetic heart valves, and Gilbert syndrome. As it is a polymer, these are hard stones, and as they have calcium phosphate and all, they are radio opaque. Whereas these brown stones are soft, earthy stones, and they generally occur because of infection. Whenever there is a presence of dead worm in CBD, then there is superadded infection, and this infection releases beta glucuronidase, which make a conjugated bilirubin into unconjugated bilirubin. And lead to precipitation and formation of stones. Okay, now it is occurring because of infection. Okay, and generally they are primary CBD stones because of this bile duct infection. So the question comes, most common type of primary CBD stone is cholesterol stone, black stone, brown stone. So the answer is brown stone. Okay, and brown stones are generally primary CBD stone, and they are rarely seen in gallbladder. It occurs generally because of infection. Black stones occur generally because of chronic hemolytic conditions. Okay, now this is common in developing countries. Okay, it is common in developing countries. So this is regarding brown stones. Okay, so now we are going to discuss the next topic. Before that, what is this? Identify this images. You can see here, these are the gallbladder stone with a Mercedes-Benz sign here. Okay, similarly seen here also, Mercedes-Benz sign. So in gallbladder stone, we can identify this Mercedes-Benz sign, which is a sign of a triradiate fissure. Sometimes there is presence of a biradiate fissure, which is known as a seagull sign. So the MCQ which comes like this, Mercedes-Benz sign is seen in gallbladder stones. Seagull sign is seen in gallbladder stones. A seagull sign is example of a biradiate fissure of a gallbladder stone. Okay. Now the next point is, what is the investigation of choice for a gallbladder stone? Okay. Investigation of choice. Now in gallbladder stones, ultrasound whole abdomen or ultrasound abdomen is the investigation of choice. Investigation of choice for diagnosis of gallstones is ultrasound. Other question. Investigation of choice for acute cholecystitis? Answer is ultrasound. Investigation of choice for chronic cholecystitis? Ultrasound. Investigation of choice for A calculus cholecystitis? Answer is ultrasound. Why? Because in CT scan images also, reports also, you will be seeing that ultrasound is the investigation or modality of choice to rule out gallstones. Okay, so for gallbladder per se, the best investigation, or you can say the investigation of choice for majority of the diseases of gall bladder related problems is ultrasound. Okay, for for carcinoma gallbladder, the investigation of choice is CT scan. The first investigation can be ultrasound, but the investigation of choice for carcinoma gallbladder is CT scan. Okay, for gallstones, acute calculus cholecystitis, acalculous cholecystitis, chronic cholecystitis, it is ultrasound. The investigation of choice, not the investigation of choice, the gold standard investigation for diagnosis of acute cholecystitis. So the next question, the gold standard investigation for diagnosis of acute cholecystitis. The answer is Haida scan. Okay, what is this Haida scan? It is hepatobiliary immunodiacetic acid scan, which is kind of a nuclear scan. Okay. So why it is a gold standard investigation? Because there is non-visualization of gallbladder. Okay. So in cholecystitis, generally the cystic duct is blocked, because of which there is development of cholecystitis. And this Haida scan, this Haida will go from the liver, from the bile ducts, it will not go into the cystic duct, and it will not go in the gallbladder. Okay, so the non-visualization of gallbladder on the Haida scan is a characteristic finding or the diagnostic finding for acute cholecystitis. Okay, so what is the diagnostic criteria on Haida scan? It is the non-visualization of gallbladder on Haida scan. Is the criteria to diagnose acute cholecystitis. Okay. Now, a question comes to you. There is a 40-year female presented to ER emergency room with pain abdomen, pain resolves after 4 hours on its own, and it is not associated with fever. What is the diagnosis? So the diagnosis is biliary colic, or the provisional diagnosis is biliary colic. Which investigation we will do to confirm? Investigation, we will do ultrasound. Okay. And in case if there is a right upper quadrant pain, fever, leukocytosis, pain does not improve in 4 to 6 hours or does not improve in 24 hours, does not relieve on its own, in these cases the diagnosis is acute cholecystitis. Okay. How we are able to diagnose acute cholecystitis clinically? Along with this right upper quadrant pain, complaint, fever, on clinical examination, there will be tenderness in the right upper abdomen. Okay, palpable tenderness. Okay, tenderness will be palpable. And while palpating on the right upper abdomen, at the tip of ninth costal cartilage, when we ask the patient to inspire, while inspiration, there will be sudden catch in the respiration. Okay, because whenever the gallbladder are distended, tender gallbladder, whenever we'll touch our finger, then patient will feel a sudden sharp pain, and there will be a sudden hold in the inspiration. Okay, so this is known as classical Murphy's sign. Okay, so there will be a sudden catch in inspiration while pressing the abdomen along ninth costal cartilage. This is known as Murphy's sign. The question: Murphy's sign is a sign for acute cholecystitis. Okay. And Murphy's sign can be elicited with both radiologically also on ultrasound and clinically also. Okay, this is regarding Murphy's sign. There is another sign in acute cholecystitis, and this is the hyperesthesia at base of scapula on the back side, known as Bowa's sign. Bowa's sign is seen in acute cholecystitis. So, now this is a Haida scan. Now we are doing a Haida scan in this patient having pain abdomen. Now this is a normal Haida scan. You can see here, this is normal. In early phase, there is CPD which is visible. In late phase at 45 minutes, the gallbladder is visible. Okay, and the tracer is seen in duodenum also. Okay, this is normal. But here in acute cholecystitis, whole of the tracer is there in the duodenum, but there is no gallbladder. Okay. So here this is non-visualization of gallbladder. This is very important. Non-visualization of gallbladder on Haida. Now there are two important questions. First, this is Haida imaging, and second, there is non-visualization of gallbladder, which is a diagnostic criteria for acute cholecystitis. Okay. Now there is a criteria for diagnosis of acute cholecystitis. And cholangitis, and this criteria is for diagnosis, severity and management. Okay, criteria for diagnosis, severity and management of acute cholecystitis and cholangitis. The name of the criteria is Tokyo guidelines. Okay. Now, the investigation of choice, I have told you for acute cholecystitis, ultrasound. Ultrasound, what all are the findings which can be seen on ultrasound? That Suppose this is a normal gallbladder. Here the gallbladder wall will be thickened. There will be pericholecystic fluid or edema. Okay, and there can be presence of a gallstones also. So thickened GB wall, pericholecystic edema, gallstones can also be there, with or without gallstones. If only thickened wall with pericholecystic edema without gallstones, it will still be cholecystitis, but it will be acalculous cholecystitis. Okay. If there is presence of gallstones, it will be a calculous acute cholecystitis. Similarly, Haida scan is for both acute cholecystitis, calculous cholecystitis as well as acalculous cholecystitis. Okay. So to confirm that it is acute cholecystitis, there is a non-visualization of gallbladder. Okay. It is for both calculus as well as acalculous acute cholecystitis. Okay. Now, gold standard is Haida. Now, what is the treatment for acute cholecystitis? This is important. If a patient is having acute cholecystitis and is presenting to us at the onset of pain or within 4 to 6 hours of pain, then we'll go for surgery. Okay. The cutoff which we generally take is till 72 hours. If a patient is presenting to us before 72 hours, then we will proceed for surgery, laparoscopic cholecystectomy. We'll start the antibiotics straight away. We'll send all the laboratory investigations, and then we'll proceed with cholecystectomy. Okay. If the patient presents to us late, then we'll manage the patient conservatively with antibiotics, IV fluid, and once the symptoms resolve, then we'll discharge the patient, and then we'll do a interval cholecystectomy at 4 to 6 weeks. Okay. So treatment of acute cholecystitis depends on presentation of the patient, the timing of presentation of the patient. If the patient presents within 72 hours, we will do laparoscopic cholecystectomy. If after 72 hours, we will do conservative management, then we will do interval cholecystectomy. We will wait for 4 to 6 weeks. Okay. Now, few points regarding the medical management of gallstones. There are two drugs which are given for medical management of gallstones, and the drugs are UDCA and CDCA. It is ursodeoxycholic acid and chenodeoxycholic acid. Both these ursodeoxycholic acid and chenodeoxycholic acid, they are helpful only in cholesterol gallstones. Okay. How they are helpful in cholesterol gallstones? Because they inhibit HMG coenzyme A reductase enzyme. So they ultimately decrease the cholesterol synthesis. Gradually, the cholesterol goes away from the stones and the size of the stones decrease. Okay. Now, what is the so they act by dispersion of cholesterols gradually. Okay. What is the indication for medical management? indication is if it is a cholesterol gallstone, if size of the stone less than 10 mm, there is no acute symptom, and if GB is functioning, then we can give the medical management. Now, what is the problem with medical management? Problems. We have to give it for a long period of time, longer duration treatment. Whenever we stop the treatment, there is a possibility that stones will again form. So, there is high recurrence. Also, it is associated with increased cost of treatment. So, these are the reasons why the medical management is generally not the preferred one for gallstones. Okay. Now, if we are not managing the patient with medical management, or if there is failure of medical management, we will go for surgery. Surgery that is preferred nowadays is laparoscopic cholecystectomy. Okay. Now, laparoscopic cholecystectomy is generally performed by using 4-port technique. Normally, we put 4 ports into the abdomen. This is the first port, that is the 10 mm camera port. Then we put second port here, the 10 mm dissecting port. These 2 ports are in the midline. Then we put 2 lateral ports, which are 5 mm. Okay. So, 2 10 mm central midline ports and 2 5 mm lateral ports. Okay. And the patient position is, in general terms, it is head up, right up position. Okay. Head up, right up position, and it is known as reverse Trendelenburg position. It is a reverse Trendelenburg position, and the head should be up and the right side should be up, so that the small bowel and the other structures fall away from the gallbladder. It will become easy to dissect. Okay. Now, a few points regarding cholecystectomy. Who performed first laparoscopic cholecystectomy? The first laparoscopic cholecystectomy was performed by Eric Muhe. Okay. Now, who performed the first video assisted lap chole? This is slightly easier to remember. Now we have Philips monitor. You just remember it like that. So, Philip Murray. Okay. Using a Philips monitor. Okay. Philip Murray performed this video assisted laparoscopic cholecystectomy. Who performed the first lap appendicectomy? Kurt Sem. Okay. And Kurt Sem is the father of pelviscopy, and he is a gynecologist. Okay. So, gynecologist performed first lap appendicectomy, and he is the father of pelviscopy. Okay. Now, there are various indications to perform a cholecystectomy. Gallbladder stones, acute cholecystitis, acute calculous cholecystitis, chronic cholecystitis are the most common, or the CBD stones are the most common indications to perform a cholecystectomy. But questions are generally asked for prophylactic cholecystectomy. Okay. Prophylactic cholecystectomy is, right now the patient is not symptomatic with gallstones or with any gallbladder problem, but even then we are removing the gallbladder. And what are the indications for prophylactic cholecystectomy are important from MCQ point of view. Indications. So the indications are heart and lung transplant recipients. So the indications for prophylactic cholecystectomy are: first is heart and lung transplant recipient. Second, if there is a prolonged TPN requirement. In patients undergoing biliopancreatic diversion. I will first enumerate and then I will explain how and why cholecystectomy is important. In patients with chronic typhoid carrier, if there is a gallstones more than 3 centimeter, porcelain gallbladder, gallstones in a patient with family history of carcinoma gallbladder, and in patients with adenomatous polyps with stone, and in chronic hemolytic conditions. But now, in heart and lung transplantation, we are using cyclosporine. Okay, so this cyclosporine increases the possibility of gallbladder stones. That is why a prophylactic cholecystectomy is required. This prolonged TPN requirement lead to stasis of the gallbladder and lead to formation of a gallstones. The biliopancreatic diversion is a type of bariatric surgery or weight loss surgery and is a malabsorptive type bariatric surgery. So this leads to malabsorption and there is formation of the gallbladder stone. So that is why a prophylactic cholecystectomy is routinely added along with biliary or biliopancreatic diversion or BPD. Okay. Now in this gallstones more than 3 centimeter, porcelain gallbladder, gallstones in a patient with a family history of gallbladder and adenomatous polyp with stone, there is more chances of carcinoma gallbladder. That is why a prophylactic cholecystectomy is preferred. And in patients with chronic hemolytic anemia, if we are performing some other procedure or if there is presence of a gallstone, then we should go ahead and perform a cholecystectomy or a prophylactic cholecystectomy. Okay. Now,